Hello and welcome here at EAO's Just Ask Live. This is your monthly appointment with a leading expert in implant dentistry. My name is Gerrit Heijkoop and I'm the host of this EAO channel. And tonight we're going to try to answer all your questions on guided bone regeneration. And to do so, I'm very honored and pleased to be joined by an expert who was a research fellow at Harvard University in the United States, who holds an honorary position at the University College of London, who is an implants dental surgeon and a specialist in periodontist with a private practice in Milan and London. Well, good evening, Isabella Rocchietta.
Good evening, Gerrit. Thank you very much. And thank you to the EAO to this wonderful opportunity.
Exactly. It's finally February 3rd, and this is our night, our evening, where we aim to answer as many questions as we can. So if you are watching this right now live, or maybe even in recording, use the opportunity that you have in a keyboard underneath your fingers where you can enter your questions about this topic, and we'll answer them as they come by. And I already asked to our audience who they are and where they're watching from, and we already gathered quite a nice international crowd. I saw from very early there, Ilkka Palonen, who is from Finland with us. Good night. Victor from Moldavia is with us. Victor, good to have you back with us again. Very loyal participants in these Just Asks. We have Philippe Breguin from Paris with us. Alberto, one of the first Just Ask participants from Alicante. I see Don Camillo from Germany. We have Martins Alexis from Latvia with us. We have Mustafa Hussain from Iraq. I think we've seen him before as well. Alice Hermet from Paris is there. Eleni Pantelidou from Cyprus. Manuel Reinigs from Austria. Wow, this is amazing. We have Florin Musiam from Romania. And also Michael Payet, the participant in the second Just Ask, is with us. So welcome, everybody. And, well, Isabella, let's take it away. If we talk about guided bone regeneration, can you paint us a little general picture? What are we talking about tonight?
Sure. Okay, so I'll start by sharing a few slides because I would like to really get into this together. And the topic we have today is something that I love, and people who know me, my friends, know perfectly well that I enjoy very much this topic, and I enjoy it for one reason, because when we are faced with a 25-year-old young lady coming in this state due to a failure to a previous attempt of in that specific case, it was a technique, Gerrit, that it's called the split graft technique, split crest technique. And it was so split that it actually failed. And bless her, it really touches your heart when you see such a young woman in the state. So in a way, thanks to guided bone regeneration, we can reconstruct and almost, let's say, go back in time with a clock and give her back what was meant to be. If in fact, of course, we can never give back teeth and we can never go back to Mother Nature per se. However, we can definitely help our patients. And these are the cases. These are our everyday patients who knock on our doors, who ask for help. And I think that we have the responsibility to treat in a certain way, ethically, in order to provide them with the most pragmatic approach and the most predictable approach. And guided bone regeneration can achieve this. And of course, these are cases where hard tissue reconstruction and then soft tissue reconstruction are in a way very, very important. I don't like to say they're mandatory because there's conventional approaches too. But if you notice, these are all cosmetic areas or aesthetic areas. And of course, you want nowadays to Gerrit to provide not only function, but obviously aesthetics. So, we would like to treat our patients like this and have the before and after so that then you can have enough bone to position your implant always in a prosthetically the right position. We dentistry or implant dentistry is now from top to bottom, as we like to say, which means from the final endpoint result to the initial. So the surgery is done with the prosthetic in mind. And we go from here to here in a very predictable way, thanks to the GBR. And whether you are in the anterior, whether you're in the posterior, that doesn't change. The technique, which we're going to stress throughout this Just Ask session, the protocol is fundamental. It's very important, and the actual surgery itself is always the same. And I will specify this more throughout the cases that we're going to see. But we never make up the surgery in terms of let's decide where to put the incision. Shall we put it there or up or down? The actual protocol is identical, and only by doing this, of course, related to the areas that you're treating, you can automate yourself. You can become better and better because you can concentrate on what is mostly important, which is precision. And obviously, if there is a complication, deal with the complication with peace and calm. I remember this metaphor that was told to me. It's like driving, Gerrit. When you start driving and you take driving lessons, you're all panicking which foot with which gear.
Yeah. It's not.
And then it just becomes automatic, right? And surgery is the same. So this is the beauty.
So you say it's a quite standardized protocol, so to say. It's a complex surgical procedure, but it's something that has a learning curve that you can learn throughout the time.
Absolutely, and the learning curve is, I must say, very steep. It's long. I suggest, obviously, that before you get into these kind of surgeries, in order not to be hit hard by failures, and also it's unethical, of course, in towards our patients, is to start small. And by starting small, I always give, the delegates who take our courses in vertical GPR, I always give them a very, very specific tip. I say, let's start, excuse me, with periodontal surgery. Let's start maneuvering the soft tissues. I always make a joke, Gerrit, and I say, take your mother-in-law and start covering a root in a non-aesthetic area. But this is not a joke. This is actually true. Start doing some perio surgery, because that creates a very sophisticated, small, like surgical, let's say, hand or skills. Because then you can then move forwards. Which
is essential before you even start regenerating bone. Now, before you dive deeper into explaining, understanding the biology and why and how we need these protocols, we hear more and more. I've been in this industry for a few years now, and the topic comes up more and more. What is driving the growth? Why are we talking more and more about this guided bone regeneration?
Well, as I said earlier on, now the implants are not just positioned in bone, period. The implants, once it was like that, when we were
if there was not sufficient bone, you would not be a candidate.
There was not sufficient bone, most of the cases you were not a candidate. I must say, guided bone regeneration was discovered, and I like to use the inverted commas, in 1989. So it's not really new. But of course, before it was a current routine in the daily practice. We can say that by the mid-90s, this was something that was done on our patients. The reason why it is so crucial and important to know about it and potentially to be using it is that nowadays the implant must be positioned in the prosthetically driven position, which means basically working where the future prosthetic superstructure will be.
Exactly.
And obviously, if the implant that you need to put there is positioned, but unfortunately there's no bone, then you can obviously regenerate bone according to certain indications. I'm not saying that you can regenerate everything and everywhere, of course. There are specific indications. And that's why the demand has increased significantly because of this.
Great. Good. In the meantime, let me make a quick shout out to all the new viewers who have just joined. We see Helga from Norway, Yili from Albania, Christopher from Sweden, Maria from Sweden, Brenda Mettens is there as well. Bonjour, Isa, she shouts out. George is there from Greece, and Miguel from Spain. So we have a great international crowd. I even see Sompol from Thailand here. So even a great geographical spread. So welcome, everyone. We are live. As you can see, your comments are rolling in on my screen as well. So if you have any questions for Isabella during this hour or so that we have together, please take the opportunity and ask your questions, because if you don't ask, you're never going to find out. So with that, Isabella,
that sounds like a nice slogan.
Exactly. That's the
and also because Gerrit, we this is nice because it's not a webinar or a lecture, or it's a just ask. So it's more fun to have a chat and to answer any remote questions rather than babbling through the slides.
Exactly. In the meantime, you do have prepared some slides to kind of segue us into the general introduction. So why don't you continue a little bit with that?
Yeah. So I thought that, I like to use my blank book, notebook, and write a little bit of what we're going to have a chat. And I like to just briefly touch the biology, not because I want to go into the details of the pure osteogenic details, because this is not the evening, and also because we would require a lot of time. But of course, I would like to touch it from a clinical perspective, and I'll show you why. Then, of course, we need to understand the why and the how to perform the GBR, and then also touch briefly on the complications, and because complications teach us a great lesson. And every time something goes wrong, Gerrit, we clinicians bang our head against the wall and get hurt. So we learn a lot. As I was saying, the fundamental principles, well, certainly the primary wound closure. That's why I'm saying it's very clinical, because when we do GBR, I like to stress this a lot. Everything has to be completely submerged. So healing must be by primary intention. And I must say, unfortunately, if I must say this word, there's been a lot lately about leaving these membranes exposed. And by these membranes, I'm talking about the non-resorbable membranes, leaving them open air, removing them after 6 to 10 weeks, and leaving everything to heal by secondary intention. Now, that is not GBR, to be specific. I mean, if you want to achieve proper GBR, it's been really that we have a lot of histology that backs us up in terms of science. The wound has to be completely closed, and also for an obvious reason, because we are also dealing with the periosteum, which we want. It's a rich source of osteogenic cells, and we really want that periosteum to be there and to be working. Let's say, of course, the angiogenesis. What is it? It's the source. It's the actor number one. We can use whatever material. We can use the magic wand, but nothing will happen if we don't have a stable clot. So the blood clot, which is in fact the one that brings then the growth factors and the differentiating factors into the lineage of the osteogenic cells, is the actor number one. And I like to say this. And that's why clinically, for example, in certain cases, we perforate the cortical wall to allow the bleeding. Okay. And then, of course, space maintenance. This is extremely true when the body or the alveolar defect does not help us. We will see further on a classification, and we can definitely divide and differentiate between something that is self-containing, which means that the actual anatomy itself keeps the stable blood clot, or a defect which is completely non-self-containing, and this is true for the very thin ridges, knife edge ridges, or the vertical defects, because of course Mother Nature can't do anything. And that's why we call it guided bone regeneration, because we are guiding the osteogenic cells to reproduce where Mother Nature cannot do it on its own. And then the last but not least, the stable wound and graft material. And I like to underline this, that when we actually put those membranes in, they have to be tight, they have to be stable. And I always tell them, come on, take the back of a sterile instrument, bang it against your membrane, and make sure there's no movement, because you're expecting, the alveolar bone to grow new capillaries, new vascularization, which like are very thin branches of a tree. And imagine if you put an earthquake there, the branches of the tree disappear, they break, and you would have connective tissue instead of hard bone. And no wonder when you open up, you have a mushy substance, which would be a failure, unfortunately.
So how you use these fundamental principles, these are like my 4 topics to check before I pass my
yes. These are, let's say, in fact, they're quite broad, but they're really fundamental. Then we can go into the detail of where to put the incision, how to do it. Yeah, but these are the reason behind our technical ability to perform a certain surgery. We have to have these 4 things clear in mind when we treat our patients, because if we don't have them, then we won't be able to carry on and to do something successful.
Great. Now, may I pause you there a second, because we have our first few questions coming in. I don't want to pull you back in. We have two questions. First question came in from Mustafa Hussein, who's joining us from Iraq. In the meantime, we also see South America joining us. We have Darlene from Brazil. We have Maria from Mexico. So we're really throughout the globe. This is really exciting. Anyway, Mustafa would like to know your comment on the timing in the protocol. So his question is, what is the time period between a guided bone regeneration and implant placement? Is there a rule of thumb for that? Is there a protocol for that? What is it?
Yes, well, thank you very much for the question. Now, the rule of thumb, depending on which kind of GBR, so we will see later on a classification. If we are talking about a minor or a less extent guided bone regeneration, and I mean when the implant is positioned at the same time of a guided bone regeneration, so you position.
Because that's possible. Immediate.
Yes, that is possible given the circumstances, given obviously the correct indications, when there is sufficient bone to have primary stability of your implant in the correct position. These are the prerequisites. If this happens, you can perform GBR with a particulated, for example, bone substitute graft and the collagen barrier membrane. And in that case, you're ready to perform a second stage, which means loading the implant or the healing abutment connection already after 4 months. So the time is relatively quick. When we're talking about big cases, so the vertical or horizontal GBR, where you need a titanium reinforced PTFE, which is the old Gore-Tex fabric, like the ski jackets, to make it clear, obviously a little bit more sophisticated than that, then you when you use these membranes and you're asking the body to the potential to regenerate large volumes, the minimum healing time is 6 months and the maximum healing time is 9 months. What is the difference? 6 months is usually in terms of size, usually 1 tooth or 2 teeth. When you get to the 3 teeth span or 4 teeth span, obviously it's bigger and obviously you need to wait a little bit more. I remember one very, very old publication by Bob Schenk, who unfortunately passed away due to age, and he was probably the histologist in Europe. I remember he speculated in this paper back in the 90s that bone regenerated 1 millimeter per month, which is obviously something that you don't have as a certain value, but it's interesting to a little bit understand as a rule of thumb, how much to wait.
Yeah, so it really depends on what kind of
but
design
in general,
or
6 to 9 months.
Yeah. Now we have 2 more questions coming in, so let's take them first. One from Gerasimos Carles, who's actually from the Netherlands, and from Guillaume Heller. And Gerasimos, if you're okay, I take Guillaume's question first because I think that answer will lead into your question. I'll read them out to you both. So Guillaume Heller is asking, do you have any data about the survival rate of implants in native bone versus in guided bone regenerated bone, so to speak? And to give you a segue to Gerasimos' question, he's asking if you think, but then I should say at EAO we're all about science, so besides your personal opinion, please refer to any science that you know, that the regenerated bone has impaired defense against peri-implantitis. So, so let's start with the first question first. So what about data of implant survival?
Okay, so there's plenty of data which gives us that the information, and one of the slides which I probably have not reported, but it's there in the presentation, which gives us that implants have a survival rate which is similar whether they're positioned in native bone or regenerated bone. And there are tons of papers, especially from the Swiss group of Ronnie Young and Christoph Hammerle. And this is implant in native bone versus implant in GBR bone, whether it's vertical, horizontal, doesn't matter. The point is, and obviously this parameter has to be taken in consideration when healthy situations are present, i.e. in absence of pathology, okay? Exactly. So this is very important. There is a physiological remodeling given by Albrechtson's paper back ages ago, and that is identical, well, not identical, very similar to the 2 scenarios. And in terms of data, in terms of long-term, we have studies by Istvan Urban and by Massimo Simeon, which are they report a 15-year follow-up, so not massive because it's very hard to go back and do retrospective studies, but certainly they are pieces of information that build up this data, this topic.
So you say at this point there are no signs on the contrary, all the signs are showing that there is no major difference and related to
no. We do have the science behind it, but it's up to 15 years. But this is for the verticals, the 15 years. Whereas for the normal GBR, we have way longer, and these are the Christoph Hammerle and Ronnie Jung papers that I was mentioning now. In terms of whether the regenerated bone, how does it behave with periimplantitis? That's a very tough question. And this is, in fact, one of the topics that I am interested in to carry out research in the near future, because we don't have much science, if not almost nothing, on the fate of periimplantitis, of these implants affected by periimplantitis, if they are originally positioned in native versus regenerated bone. And this is something that I think we should investigate, whether the regenerated bone is a vehicle that stops or accelerates the process of periimplantitis.
Yeah, so basically the short answer there is this is research that needs to be done.
Anyone out there needs to be validated. Needs to be validated, definitely. I've spoken to a very Jan Dirks, who's probably the person who has published recently on periimplantitis most knowledgeable, and he has confirmed that at the moment the literature is there, but unfortunately not on this topic, because when the authors have written about periimplantitis, most of the times they have omitted this information, whether the bone was regenerated or not.
Exactly. So interesting topic, and maybe something more about in the future. Thank you for your question, Dirasimos. More questions rolling in, so I'll keep pitching them to you. Next question, obviously we touched on the topic of materials, and we have several questions on materials. First one is about the membrane that you referenced. It's from Frank Renoir, I hope I pronounced that correctly. And he says, yes, what about the periosteum as the most natural membrane? You quickly referenced to a titanium membrane. And maybe when we talked earlier, you gave me a very clear explanation about which membrane to use when. So I think this is perfect time to give us that.
And remember when I mentioned about the driving, that we automatically first, we are, and it comes from Frank Renoir taught me this. So
it's an honor to have him with us tonight. Yes.
Definitely an honor. And the periosteum, as I said, is a fantastic source of osteogenic cells. This is out of discussion. And in fact, there have been papers and attempts to perforate the titanium reinforced membranes. So let's make a little step backwards. The reason why we are still nowadays, even though we're in 2020, using titanium reinforced membranes, which in fact were initially published in 1994 by the group, for example, Massimo Semyon, Sasha Jovanovic, and all of the big names in the vertical GBR. And in fact, if you think about it, nowadays we're still using them. The only difference compared to the past is that now there is a tendency to use a dense PTFE rather than an expanded PTFE, which in a way makes sense for the introduction of bacteria in the site. But on the other hand, it blocks the famous osteogenic cells from the periosteum, as we were saying. So there's a bit of a fight between, I need something that keeps the space, hence the periosteum would be great, but alone we cannot use it, because of course you need to have something space that it keeps the space. Yeah. And that's why there is the introduction of, for example, titanium mesh. 3-dimensional titanium meshes, which of course have the benefit of keeping the space, but on the other hand, they're not cell occlusive. So it's a bit of a fight between, not a fight between individuals, but a fight between the science in understanding the real role of this layer of periosteum, the osteogenic cells, on whether it is actually, how much of these should be entered. To my knowledge, there is no paper that has ever looked at this very, very, very carefully. So it is very hard to say, yes, we should do this. Yes, we should avoid these cell occlusive membranes versus keep the mesh open and so on. We have done a lot of studies in the past with a platelet-derived growth factor, which attracts those cells of the periosteum. And one thing can be said for sure, that when those cells are activated or are stimulated by growth factors, we found bone everywhere. So it is an extremely strong and potent layer. There is a fantastic researcher called Molly Stevens. She is a young woman. She is head of one of the departments, if I'm not mistaken, at Queen's Mary Hospital in London. She's not a dentist. She's a pure scientist. And she, for example, has published a lot, and I've seen her work by lifting this periosteum through a very small incision, and obviously this is all animal studies, nothing on humans, and recreating enormous volumes of bone just by creating a tenting effect, just by leaving the periosteum. So possibly this is the way forward, but from a technicality point of view in our patients nowadays, apart from the titanium mesh, we still cannot do this without the incision, which of course means breaking the periosteum. Gosh, I hope this was not too long.
This was clear. Yeah, no. I could follow. And
Gerrit, I can see you lost with these cells.
No. I'm also checking if I can attach some questions that are rolling in the meantime. But no, it's a very clear answer. And what I remember from our pre-talk, it also all the type of membrane you use depends a lot on the amount of containment there is, right?
Yes.
Exactly. Now, next question from Pascal Valentini, which is slightly tied in what you just touched on, because he's asking, do you think mixing any LPRF with biomaterial could improve the results in terms of bone quality and healing time? And I'm always careful with this. Do you think? Please distinguish about what you think and what we know from
There
science.
is a reason why Pascal, who's probably one of the most talented surgeons in France, has asked this question, because the LPRF, even though it is absolutely not new, in fact, the concept of the platelet rich, let's say, plasma or fibrin is very, very old, if I may say. But the LPRF is something that has been out there recently with various publications, and in fact, we have had a consensus conference of the EAO, where the author was Mark Quirinen, who is in fact the person who is lecturing a lot on LPRF, and they have shown that at the moment we have absolutely not any data or scientific evidence that the LPRF has a beneficial effect on the bone side of things. What they have been shown clearly is on the healing side of the soft tissues. So we're not talking about the bone, but the soft tissues. And this is something obviously to which the two things go together. So the answer would be, I'm not 100% sure whether this would benefit the amount of the osteogenic potential, the bone side. But we have seen that for the time being, even though the data is very scarce, but it is very promising for the soft tissue point of view. So it could be a good idea, potentially, to...
And that is exactly his wording. Pascal is writing, do you think it could improve? So that would be a yes then, but there's no data at this point to prove that.
Yes. More on the soft tissue, more on the healing. And we know that for the big vertical GBRs, the healing is an issue. So we want to protect this healing as much as we can. As I said earlier on, remember I said about the submerged healing, then this could be obviously a very good idea to have a study, a comparative study, whether by positioning right under the suturing level, so under the flap, this could benefit, which probably the answer could be yes, but who knows, we cannot.
Exactly. There seems to be a potential there. I think I hope someone is taking notes, because I think we're ticking off a lot of future research to be done in this field.
Yes.
Right? I mean, we're touching all these topics that we say more research is needed. Next question that rolled in was from Saif Khan, we're talking materials again. He says, does bone particle size matter in GBR? And if so, how does it matter? That is my objection to that.
Well, in reality, yes, it does, and it's a matter of surface area. So the small particle sizes that have been shown histologically to be more favorable for the autogenous bone to basically bridge from one particle to another. Because let's remind ourselves that the bone substitute works as a scaffold. So what we're putting in there has to serve, as I was saying, to the tree, to the branches to build up and to bring the blood that then through its growth factors differentiates the cell into the osteogenic lineage. So yes, it does matter, and that's why, for example, in nowadays you can find small particles or larger particles, and in fact we've always used the small particles due to this phenomenon. And in fact, I find it also, let's say, easier, if we can say this word, to manipulate during the surgery rather than the big bulky particles that go here and there. It's they're less neat, the bigger ones.
Exactly. Well, Saif says already very good and very informative, so he's quick on that. And in the meantime, let me welcome all the new viewers that have just joined us. We are live. We're doing a Just Ask about guided bone regeneration with Isabella Rocchietta. If you wonder where we are, well, the questions are pouring in, so you can read along in the live chat and you can see where the questions are coming up. And while I say that, more and more questions keep coming, Isabella. So yes, have a sip of water and we'll move on. Now, Helge Oiri from Norway is asking a question that might get us off a bit, because he's asking, do you have any experience with a relatively new product? And then he says, between brackets, ETH ... Well, if he doesn't know what it is, how can we know what it is? Which is to work without a membrane. Do you know what he might be referring to? And if not, Helge, please clarify your question. We'll get.
Honestly, yeah. No, I'm sorry.
Okay. We'll quickly move on to the question from Johannes.
Hang on a minute. Maybe he means the custom-made titanium mesh.
Maybe he does, but let him clarify that before we start guessing. Okay. So Johannes from Musis would like to know, would you perform an extended GBR? Here is Helge. Okay. Ooh, we're live. Okay. So he's referring to ethos from York. Yes. Have you heard about that? And then his question is, do you have any experience with that?
The answer is, I don't know. I know about it. I don't have any experience with that. So,
for our viewers like myself who don't know what ethos in York is, can you?
But let's I think move on. Otherwise, we have loads of questions. But again, not having the experience, it doesn't make any sense to make any comments about it.
Good. All right. So Johannes Formusis, then, here's his question. Would you perform an extended guided bone regeneration in order to insert implants in the aesthetic zone? And he then later clarifies, for long-term results. So in this case?
Yes. Well, yes, definitely. Because, for example, the next slide that was going to come up.
You can put it up if you want.
No, it's fine. It's fine because it's just wording, so I can easily refer to it verbally. It's the latest EFP and Osteology Foundation. They put together a group of us in a consensus conference, and funnily enough, it's the first time that the word aesthetics, so aesthetic areas, as the question was referring to, comes into play when it is defined why we should be performing GBR. And the reason behind this is for the stability of the peri-implant hard and soft tissues. So the answer is absolutely yes. So obviously you have to balance between the ethical of, yes, I'm going to do a GBR, hence the patient is undertaking a surgery, because if you can do and achieve the same with a much less invasive procedure, then of course we should opt for a less invasive procedure. But GBR has a specific indication. So most of the time when you actually do GBR, it's because you can't avoid it, if that makes sense. It's not something like, yes, I could avoid it, but I'm going to do it as an extra addition. Normally it doesn't work that way. It's either you need it, and yes, if you need it, it will hold on for the long term, the peri-implant hard and soft tissues. I hope I've explained it well.
That's a clear answer. So it's a yes. Now,
it's a yes.
Next question is from Victor Palari. Victor, thanks to have you with us again. And he's asking, Isabella, could you explain when and where we can use growth factors, such as PDGF? And please give me that abbreviation, Isabella, first.
Platelet-derived growth factor.
Exactly.
And, the PDGF. The answer is, of course, it would be fantastic to use. It has been approved in 2006 by the FDA for periodontal regeneration. So when you use it on, for example, vertical GBR, you use it off labels. Hence, you can't use it. Bottom line. So there are many countries where you cannot use it. There are countries where you can use it. But again, I reiterate for periodontal usage, the PDGF has been shown, as I was explaining before, through a lot of our studies and human histology and animal histology, that is an extremely strong growth factor. It's recombinant human. So you buy it and you purchase it as a liquid, as a transparent liquid, and the potential is enormous. The problem is that we can't use it. And this is really annoying if you think about it, because we've demonstrated that it could work, but it's very hard to use on an everyday basis.
Exactly.
For approval for legal purposes, not for medical purposes.
Do you expect this to change in the near future, or is this status quo?
No, because as I said, this was a battle that started in 2006. We're in 2020, and still we're very behind. So I'm afraid this is going to be a hard thing to overcome.
Okay, so mainly in periodontics. That's it.
Yes.
Yeah. All right. And next question from Gerasimos Karlis, again from the Netherlands. He is very thankful for your answer on peri-implantitis, and now moves on to the question: what do you think about the long-term stability of the large bone regeneration with DPTFA membranes, for example? Does the bone eventually resorb to its previous position? Yes or no? What do you think? What do you know? Let's put it like that.
Yeah. Yes, please. Again, the answer is Van Orban has published a 15-year follow-up, and Massimo a 20 maybe. It doesn't go over 20 years. I apologize if I do not remember the specifics, who has published what, but one has published 15 and the other has published 20 years. And the answer, as I said, yes, there is a long-term stability of the vertically augmented regenerated bone in absence of peri-implantitis or any sort of pathology. So the answer is yes. Let's remind ourselves, and this is a little clinical thing, that we have modified our protocol many years ago. And this bone that I like to call baby bone, because to go back to the first question, how long do we wait? When we rebuild big ridges, we wait 6 to 9 months. Now, even 6 months is a very short time frame, and even 9 months according to the site. So when we go in, that's called baby bone. It's not 100% bone, it's 40% new bone, approximately 60% scaffold. Now that is very fragile, and throughout the years, decades, it carries on in the evolution and in the maturation. So we have positioned our implants slightly subcrestal and covered the crest with a little layer of, for example, deproteinized bovine bone mineral, which is a slow resorption biomaterial, not to regenerate more, but in a way to protect the natural, the physiological remodeling around the implant shoulder or the implant neck, which then would affect potentially the aesthetics, for example, a recession. So you see, we have kind of, it doesn't reabsorb, it doesn't disappear, let's put it that way, but there is a remodeling. And this remodeling is annoying when you're in the aesthetic area. So we try to, trick the bone by positioning the implant slightly subcrestal and by covering it with this layer as a let's say as a shield, as a protection.
Yeah. So at the point of design or architecting it, you kind of mitigate for that effect later on.
Yes, it's in fact when you position your implants, it's an implant positioning. For example, we do not position the implants under contouring the site. So basically, Gerrit, when you position an implant, you prepare the site. So you make a hole. You make a hole, and most of the times when the bone is soft, you under prepare so that the implant, when it goes in, it kind of encapsulates the native bone and it gives you the solidity or the primary stability that we're looking for. We have seen that this is negative for the baby bone, for the regenerated vertical bone. So we always prepare the site slightly less than the implant diameter, if not at the implant diameter. And the engagement is on the native bone to get the primary stability. And even if it's 20-25 Newton centimeters in terms of torque insertion, that's fine, because you never load the implants in baby bone. So you give time to solidify.
For it to strengthen. Yes, very clear, very clear. All right. Next question. Maria Branco from Mexico, if I remember correctly. And now
Hola.
here's a different word. So let's see if I pronounce that correctly. A difficult word, I was going to say. Is there a difference in the cicatrization, I think she wants to say, cicatrization time
like
between
scarring.
between the different types of membranes?
Scarring, cicatrization, because I don't know this word. Probably it's scarring, and no, I don't think, there's no difference in terms of soft tissue appearance. Maybe she mentions when, maybe we can ask her if she means in case of an exposure.
Exactly.
Maybe. So if the exposure of a collagen membrane versus the exposure of a dense PTFE membrane makes a difference in the scarring.
Well, Andreas Giannopoulos is jumping in, and he says she means healing. So is there any difference in the healing time between the different types? Thank you, Andreas.
Thank you.
Thank you. Alberto is now jumping in all caps as well. Thank you, Alberto. Very clear.
Thank you. Yes, no. And the answer is yes, of course, there is a difference in healing. The collagen barrier membranes require faster faster healing. So as we said earlier on, 4 months, and whereas the non-resorbable membranes require 6 to 9 months of healing, submerged healing. Absolutely, you can't enter earlier than the 6 month time frame.
Exactly. So it's a clear effect on the protocol later down the road. Clear. Well, thank you, team. Let's say that to all our viewers together to clear that out. Sorry, Maria, you're from Sweden. The other Maria is from Mexico. Sorry for my mistake. I shouldn't make guesses, right? That's my lesson here. So anyway, we have 2 questions related to the use of tooth or teeth. First question is Floran Murasan. He asks, do you use teeth grind as bone substitute? And related to that, Saif Khan is asking, can we use tooth as a bone block? It's not exactly the same question, but can you comment on the topic? Where are we? What do we know?
Okay, now let's make a preamble. I have never used the tooth grinded my English terminology as a graft. However, I was in Israel 2 days ago for a meeting there for the Perio Society, and I was talking to Zvi Arzi, his name, who has published on it, and he's actually published on the use of this as a bone substitute. To be very honest with you, I do not know the results of it, and I don't want to be skeptical because I don't know. So I have, and again, my opinion counts as 0. So until I read those papers and there is more science behind it, then we can obviously say something. Yeah. Using a tooth as a block, I've never heard of. I mean, there's what we call the socket shield technique, which uses part of the root as a saving maintaining the alveolar width, but that's a completely different story. So using the tooth itself as a block, considering all the different origins of the tooth itself, the enamel, the dentine, the embryonic origin of these, I'm not 100% sure this could work. And then why? Because I always start from this principle that if we have a solid, very, very backed up by science method that brings to the patient a certain result, either there is a groundbreaking thing that changes our life in terms of making something easier, making something faster, making something with less morbidity to the patient, then of course it must be taken in consideration. But using a tooth, I don't know. I'm a bit skeptical.
Exactly.
But I don't want to say no or yes because it's not. I'm not in this.
This is an area that we need to move in further in the future. Once again, I guess. Well, thank you for bringing up that topic and bringing up that question. Now I'm very excited to get to Don Camillo's question, because remember in the beginning of our Just Ask Isabella, you focused on how this is such a surgical protocol and how it's so important to get that done. So Don Camillo has asked, well, about 10 minutes ago already, I think, dear Isabella, I am now very excited to see how and where you place your incisions. And I think you have some cases prepared for us. I don't know if that would be a great timing to actually talk us through one.
Okay, so let me have a look. So let's skip. I think we should skip because we've chatted a lot.
Just jump straight into a case where we can nicely see the key learnings about.
Okay, then let's meet Paul.
Yeah.
Wait a second. Let me
share
my presentation.
There you go. Yeah.
And
put it in play mode.
Move this here, and let me put the play mode. Let me see if the video, because I prepared a video for you guys.
I think it will work. Let's try.
Okay, there we go. So
Is it
let's
running on
start.
your end?
No, 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 no.
Oh, okay, good. Because I was
There.
like,
Oh,
now it's
music.
moving.
Wait a
Yeah,
minute.
now we don't hear the music. We're good.
I don't know how to put this down. There. Is it better?
Yes, it's perfect. We don't hear the music at all.
Okay.
We see the video.
So there is a mid-crestal full thickness incision, and then there are 2 vertical releasing incisions every time we need to release the flap in a very important way. Now there is once this is performed with a hockey stick, you can elevate the flap full thickness. Now here is the bleeding from the incisor canal, which is something that we can talk about. Cleaning the bone crest is fundamental from all the remnants. This is harvesting the autogenous bone. Now that bone scraper is massive. I don't use it anymore. I use small scrapers. The PTFE membrane is secured on the back of the palatal or lingual side first. And 50% of autogenous and 50% of xenograft is delicately, you see how I suction it with a gauze, delicately positioned to be able to recreate the volume that is required. And then the membrane, the PTFE membrane, is very much pulled and secured with tacks or pins or screws. These are self-tapping screws to be able to have a nice solid volume. There is then the releasing of the periosteal incision, which is, we can spend the full day on it, which is fundamental because this is the key. And we have really changed our way of releasing the incision, also thanks to Isvan Urban's very interesting papers, and in order to release it in this sense. Now, let me put the volume up again, so I can hear you well. Is that okay?
Yes, it just went really, really fast, but yes.
I know, because it's a very fast video. If you want, I can play it again, if that makes sense, because I just had to kind of give all the pieces of information.
I saw that. I love the live commentary, but just maybe reinforce the key takeaways that we need to understand from that.
So the key takeaways, well, I have the case photographed. So obviously
yes.
Because this is Paul. So the most important is when we perform this surgery is to have a mid-crestal full thickness incision. And this is very important because what we want is the maximum thickness of our flaps. So no partial thickness, no being scared of cutting too much. It really has to be one very clear line that cuts to the level of the bone, and that's why we're cutting, in fact, the periosteum, which is not ideal for some circumstances, but this is exactly what we need. We need to access to the bone. In terms of vertical incisions, ideally, I would avoid, like I did in his case, to do a vertical incision on the distal side of a central incisor due to cosmetic or aesthetic reasons. So I would extend it to behind the laterals. Depending on the area to treat, of course, you don't want to have a scar in the mostly highly aesthetic area. It also must be said that the vertical incision has to be beveled, which means that the scar after the surgery will be less visible, if not almost invisible. But of course, you have to be careful in beveling it very well. So to answer the question on the incision, it has to be at least 1 tooth away from the area of interest, possibly 2 teeth away. The reason why we are 1/2 teeth away is because we do not want the vertical releasing incisions to be close to the area where we are augmenting vertically with these membranes, because that could be a potential source of infection. So the last thing we want is to have this. Shall I go on?
Yeah, please.
Okay, so this is Paul, and he's presenting the anterior, central, and lateral, which normally the 2 teeth adjacent to each other are the hardest because, of course, we are lacking the interdental bone rather than just one side. We see the large incisor canal, and we see a big, a medium, let's say, vertical defect. And we also see now the before and after. We've seen the surgery in the video. We see the before and after, and we see that we have rebuilt the nice convexity of the ridge. So it's nice and rounded as it was, almost as if we were coloring it in, which is obviously nice to plan our implant placement. After 6 months, we are reopening the patient. Remember the timings that we've mentioned so many times. And when we reopen a case that has worked well, which means that has had no infection or no soft tissue dehiscence, it's lovely to see always the same exact appearance, which are these membranes are adapted to the underlying soft tissue, and they peel off very easily compared to a titanium mesh, which by definition titanium integrates with bone. this titanium frame, it looks as if it's a mesh, but it's not, because it's in between two layers of PTFE. So when you peel off this membrane, this whole thing comes out together. So once it's peeled off, and you may notice that hello?
Yeah, we're all still there. Yeah.
Okay, sorry, I heard it. Bam, 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 bam. And you may notice that the actual ridge is fully formed, and the actual incision line and surgical approach is smaller, because we don't need to open a massive flap again. We just have to access the screws that hold this membrane in place to remove it. And when we peel off the barrier membrane, you can see what I like that this close-up picture shows is the vascularization. Remember, I was talking to you about the branches and the trees. You can actually see them, which makes you, feel good, if that makes sense, that you're actually rebuilding something which is alive, which is not just an inert piece of something. And in both directions, you can see that we have rebuilt the ridge. Of course, it's flat, so we will then have to work on the provisional restorations to recreate the incidence of a pillar. But definitely, this is a volume that has been nicely regenerated, and now we can then put our implants in the correct position. Okay.
And to be clear, this is a case in the aesthetic zone immediately, right? You're taking us straight into Champions League level.
Well, yeah, not really, but yes, absolutely. Where we're trying.
Well, I think we're all just jaw dropped looking at this, Isabella, because our questions have kind of silenced at the moment. If you're just joining us, if you have a question on any of the things you see here on screen or anything you hear Isabella talk about, please use the opportunity to send them in via the live chat. In the meantime, Isabella, this is great. So if you could share the case of Nina with us as well, please talk us through it.
Of course. Nina is a 29-year-old girl who had a very, her history, I saw her in this state for the first time. And she tells me that she has had an extremely large periapical lesion due to a fracture and a trauma. I honestly cannot remember the details well enough, but I remember her sharing with me her CT scan of her upper right central incisor, which was really, honestly, a huge periapical granuloma. And she went to a dentist who decided to perform an immediate implant placement. And now, Gerrit, we could open up probably a 5-hour conversation on the pros and cons of immediate implant placement, but we're not going to go there because this is not the topic.
Mm-hmm.
So
maybe for a future,
for the future, right? Yes. Yeah. He performs an immediate implant placement, and with the use of a particulated graft, which was completely unknown, because I then called up this colleague and I asked which kind of particulated did you use, and he just gave me a random name, and I think I know a lot of biomaterials, and this was a little bit unknown. He didn't use a membrane at all, just like that, and he closed the flaps. And the result was a complete failure. The implant fell out, and the particles were embedded, and nothing had regenerated. There was a lot of connective tissue, and I saw her in this state when the implant had just fallen out, and you can notice the hyperemic soft tissues that are suffering. And obviously, this is not a huge case or a massive case, but when you have a very young lady who is bound to get married, she was getting married after a month, you're kind of taken aback and say, okay. So I told her, well, great, we're not doing anything. So for the first thing, I'm going to give you a good, nice old adhesive resin bridge, a Maryland bridge. You're going to have your beautiful day with a nice smile as much as we could, and we're going to let this tissue heal, because that's the most important, respecting Mother Nature, keeping this healing for a long term. And also remember that when you use particulated graft without a membrane, these particles embed in the soft tissue. And when you have to release the periosteum, as we saw briefly in the video, it's extremely, extremely hard, because it's almost like rocks in the connective tissue. So it's definitely not something that is favorable. However, after that period when we gave a Maryland bridge, this is the CT scan that was taken after, when she was then ready for surgery. And if you notice all that strange kind of bumpy appearance of the defect, those are the remnant of the biomaterials, which during the surgery I have removed just in case they were potential cause of any sort of infection or anything, because I had, again, had no clue of the origin of this biomaterial.
Yeah.
And you can see the destruction that occurred. And of course, probably she was starting with a case that had blown out all the buccal wall. And that's why an immediate implant was a mistake in the first place. And this is what the patient had to pay. What I'd like also for you guys to notice is the lack of the attachment of the adjacent teeth, because she has lost clinical attachment level, especially on the lateral, which, as we know, the indication for GBR is from bony peak to bony peak. So there's a limit to how much we can regenerate. There's a limit to how much we can give those beautiful pink papillas in the future. This is a very new case that I've been treating. So there we go with all the planning and the CBCT scan. This is the soft tissue appearance once everything has quieted down, like has calmed down. And in all its directions. So we notice quite a large concavity. So it's not massive, but of course it's something that has its aesthetic challenge, because every case, even people who say it's an easy case, I find the word easy inappropriate for what we do, because even the micro mistake then can hit you very hard in your back. Exactly. and that's not the case. So there you go. So as you've seen from the video, a vertical releasing incision, 1 tooth away and 2 teeth away to stay away from the area. All the bone is nicely cleaned. So now finally we are on an area where it's fully bone, and we are ready to regenerate. We start by positioning our barrier membranes, which we have previously cut into the right shape, on the palatal aspect, so that it works almost as if it was a new wall, where we can then apply our biomaterial composite. So the biomaterial, as said, it's a 50-50. So we have the osteogenic induction of the autogenous bone, and the osteoconductive, so osteoinductive and conductive properties of the scaffold. So in a way, we have the best of both worlds. Then the membrane is securely tightened, as I said, on the palatal aspect, and then bent over and closed, as we saw from the video. It's nice because when we perform these surgeries, we never overcorrect. Whereas when you use the collagen barrier membranes, you have to overcorrect to basically counteract, if that's the word, the pressure of the overlying soft tissues. Because when you suture, and there's a very nice study by Mary, I always mix up this E and A, publication recently, where at the level of the implant shoulder, which is where the aesthetics is mostly important, when you use a collagen membrane and you don't pin it and you don't stretch it and you don't make sure that it's nicely tight, of course, when you suture, the pressure of the muscles, the pressure of the flap squishes it, squashes the area, and hence decreases significantly the horizontal width. This is obviously doesn't happen with the titanium reinforced, because it's hard enough to counteract this pressure. And this is the reason why you don't have to overcorrect, because whatever you see in that bulky composites graft, as we saw from the reopening, that's where it actually forms. So we don't have to do this. And this is another very important part of the planning, of the procedure. Now, the membrane has to be far away from the teeth, because if it touches the adjacent teeth, these kind of membranes get infected through the sulcus. So the last thing we want to do is that. The reason why we cover up now on a routine basis with a collagen membrane on top is not to spend more money, but it is to make sure that the gap between the PTFE membrane. Can you see in the portion on the left-hand side of your screen, there's a little bit of graft exposed, and we want to make sure that graft is fully covered under the principles of GBR. And you may notice that the collagen membrane can attach to the adjacent teeth, because it goes into then a process of self reabsorption, so it doesn't give any harm. Let's carry on. Then this is the healing process. You may notice how horrible the provisional looks, but it has to be like this. It has to be fully shortened to avoid any whatsoever pressure on the underlying structure. Otherwise, we will get a failure. And then we have the process of the healing as we go on, and we have a nice resolution of the concavity. So obviously this is whether it's the aesthetic or non-aesthetic region, what we want, as we said at the very beginning, is to make sure that the patient goes back to having a nice volume. When we reopen, they all look basically identical. You reopen with a smaller flap, you go and make sure you write down and you take pictures of where you've put the screws and tacks to secure these membranes. We take them away, we remove the membrane, and we have a nice vascularized surface. And now we can then proceed with our implant placement. This is the before and after. We put our implant, as you see, slightly subcrestal, and then we go for the usual process of positioning. What I like about this image is not only the obviously the one on the left, which gives you the nice curve, but the one on the right shows a nice boxy shape. So a nice thick box shape. And that is very important for the stability on the long term, because this patient is young. If we could have waited even more to put the implant, even better. Now she's 29, 30. She came there, she was 29. By this stage, she was 30. So that's an appropriate time on the young side of it to position the implant. But mainly we want that implant to have a lot of thickness on the buccal portion to protect her from potential recessions in the near future. And this is obviously the 3D reconstruction of the before and after. And you see how nicely the volume is recreated. And then, as I said, she's a new patient. Let's see if this goes on. There we are. And then we get into the arena that David Nizand in his Just Ask last month has done. About the soft tissue management. There are so many different ways of three main different ways of when to and how to augment. Bottom line is, in her case, we wanted to augment the thickness of the soft tissues again to be able to play around, let's say, with the future blanket, and to play around with a provisional restoration to be able to then adjust it appropriately. And then she's ready for the prosthetic phase.
Super clear.
Should I carry on?
No, because we have collected some questions. No. We were just listening breathless to your explanation of these two cases. And I think they very well illustrate a lot of the things you've been mentioning through your answers to the questions. But we're about 60 minutes down the road. We say these Just Ask last about 60 to 75 minutes. So just let's use the last 15 minutes to get some more questions answered. And these first three came in kind of right after you were introducing Paul's case, or you were done introducing Paul's case, and I think you built on that with Nina's case. Andreas Giannopoulos would like to know, so what do you think about removing or leaving the membrane stabilization tacks or screws at re-entry of a resorbable? And then his follow-up question is, are we causing more damage to the baby bone by raising a big full thickness flap?
Mm-hmm. Now
and both, I would like your clinical perspective and if you know if there's any scientific relation.
Absolutely. Well, the question is very, very pertinent, and the tacks that we use on the collagen barrier membranes, he's absolutely correct. Most of the times we leave them inside. We do not raise a big flap because we know that obviously this could encounter in a small portion of bone resorption, so we leave them in place. That's why I tend to avoid tacking the resorbable collagen membranes on the palatal, not on the palatal, on the lingual aspect, because the lingual, there's the sublingual fossa, and the last thing I would like to is to have a tack for the rest of the patient's life in the sublingual area. Mm-hmm. So you never know that this may become dislodged in the future, and we know that that is a very, very dangerous zone. So what I do, because we are talking about collagen membrane now, so it means that there is a bony support by nature, which is supporting part of the graft and part of the membrane. So normally the lingual side, when it is represented, it with the flap itself, it holds the membrane in place, and then I stretch it and I pin it only on the buccal side. At that stage, those buccal pins can be left in place because they are titanium, they are inert, and that's fine. They're stainless steel, they're not titanium, so I don't want to say things that are not correct. Apologize for this. Now, when we are using, on the contrary, a PTFE membrane, the membrane has to be removed. period, that you cannot leave PTFE under. And by the way, it has happened that remnants, the corner of the membrane was not peeled very well. You do not realize, you close the patient up, and then 6 months, 6 years, 4 years, whenever down the line, you have a fistula, an abscess, and everything goes bonkers because of the remnants, because you're leaving something that is plasticky underneath. So what I'm trying to say is that when you remove those membranes, because you have to remove the whole membrane, you have to access the screws. So might as well get rid of them, and you're not compromising anything.
Yeah, exactly. Clear, super clear and passionate answer.
And passionate, yay!
Yeah, yes. Now, Ilka Palona was asking, have you had any problems with reconstructing GBR bone volume with large congeniality missing permanent teeth areas, with no issues, with no issues on the primary healing? So
wait a second.
Yeah, exactly. I was reading that as well, but let me just read that out slowly to you. So, first part of the question is, have you had any problems with reconstructing GBR bone volume with large congeniality missing?
No, because the answer is according if the anatomy allows it, which means if you have a bony peak to bony peak, a U shape to make it clear, then it's absolutely feasible and it's predictable.
Clear. Let's leave it at that for now.
Let's leave it like that.
Then there was a question from D. David, who is complimenting you on what it looks, but then he kicked off an entire kind of sub-discussion in our chat on allograft preferences, because he asked, do you have any preferences for allografts? I won't read out all the comments left or right. Let's just hear your preference, either from a clinical perspective or from a science-based perspective.
Okay, as we know, there are many categories of grafts. We can have correctly so the allograft. We can have the autogenous grafts. We can have the xenografts. Now, the xenografts are the ones that I must say have let's say the more pros, if we can use this word, simply because they are slow resorption. So it means that initially we thought this was a negative side, because we said, oh, come on, we really want autogenous bone to kick in. But then we have seen, and by saying it's saying it's the literature that has been showing that in fact for the long-term maintenance of volume, this is actually beneficial. So this is the reason why the scaffolding is chosen more into the xenograft arena rather than the allograft arena. Not saying that the allograft wouldn't work, but it has a resorbability pattern which is completely different, and it's much more rapid. So I favor something that keeps maintaining on the long term the volume over the decades.
Exactly. Well, very clear. And I think we can do an entire Just Ask or an entire discussion on this one as well. So thank you all for participating in that. And then this is fine. Have a discussion amongst yourself. John Dipsey just comes in with a question and says, hi, what protocol do you follow with temporary partial denture, between brackets, a flipper, in the aesthetic zone immediately after guided bone regeneration?
So in theory, you should not use them. You should absolutely not use them. The preference of choice is something that is fixed, because you have to, as mentioned, avoid any kind of pressure whatsoever. Now, we always fight, David and myself, David Nizand and myself, we're very good, we're friends, and we always fight because I say categorically no removable dentures in the area, whereas he has taught me that if you have a very good, study lab technician who really performs a removable denture with a complete palatal support. For the aesthetic region, of course, we're talking about the anterior area. Then, as long as there is absolutely no pressure, go for it. There's not a problem. One other option would be the Essex retainer, which is not aesthetically amazing or appealing, but it's very easy to flip in and out for the patient and for the dentist when they have to remove the sutures and so on. Very cost effective, very cheap. So if there is financial issues, that's an option. But again, bottom line, it's very simple. You have to avoid any kind of pressure, period. So if you manage to build that, then it's absolutely fine.
then it could be working. Well, thanks for sharing that. Yes. Then next question came in from Johannes Vermoeses, and he says, what do you expect in the case of the young lady? So your second case, Nina, I remember her name, 20 to 25 years down the road. Native alveolar bone keeps growing, but the implant stays stable. How would you correct for that then?
Well, to be honest with you, she's 30. So
she will have 20 to 25 years ahead of her.
No. I'm not saying that. Gosh, I mean, I wish she will have 100 years in front of her. No. I'm just saying that the growth there is from the consensus conference of the EAO of 2 years ago. There was a fantastic review of a very, very good orthodontist telling us that in reality, the growth, I agree, that carries on throughout life, but there's a maximum spurge or increase in terms of adulthood. Of course, I'm not talking about teenagers or in growth, between 20 and 30, which meaning that at the age from 30 onwards, it is less evident. And these discrepancies are probably going to be manipulated with, let's say, changing the crown, obviously if there is a discrepancy with the incisal margin, but I would not expect anything major than that, if that makes sense. If the patient is 20, 22, 25, we tend not to put implants anymore. We tend to keep them as much as we can with Maryland bridges, with other prosthetic appliances, whatever they want, but we try to convince them to wait. And normally we ask them to wait until they're 30, funnily enough.
So that is how you mitigate, right? You just don't consider them as a candidate at all.
Well, we try. But
of course.
Depends on the case.
Their decision. Yeah. I think we're nearing some of our last questions. Sasa Marin is asking, hello, what protocol do you use in the case of exposed collagen, bone block, and PTF membrane? Exposure collagen, I should say.
Yeah, when the collagen membrane gets exposed, or when the block gets exposed, or when the PTFE gets exposed. So it's 3 different scenarios. Gosh, how much time do I have? 3 hours, 4 hours?
Just a few minutes. No, guide us where we go find more about this, I guess.
Well, as we know, the collagen membrane is the one that heals better because it will heal by secondary intention, because it goes through a natural process of immediate resorption when it's exposed. And that's why they say, don't worry if you have an exposure of the collagen, which is true. You will have a little scarring and an indentation of the soft tissue. It's not ideal, but you can deal with it. Mm-hmm. The exposure of a block, that's more serious because it's a vascularization issue. So you may end up with having a necrosis itself. And
I think we just lost your headphones. I think battery is down, but we can still hear you now through the computer laptop. Yes.
Okay, and I hope it's fine.
Yeah.
Okay.
You're a little further away, but we can hear you. I think it's a clear signal. Our time is almost up.
I will raise my voice.
Not too much.
And the PTFE membrane exposure, in fact, is it's way more difficult to manage, and we can really there's a lot of things to say about this. Bottom line is you need to make sure it doesn't get infected, so monitor on a weekly basis, and at a certain point, depending on when the exposure is, the membrane has to come out without any doubt.
Exactly. Now, with that, and we still have a few questions rolling in, but let me say to those viewers, well, thank you very much for participating, and please keep coming back to these monthly meetings online, because we will be having more in the future. Because, for example, Isabella, we started off saying guided bone regeneration is all about getting the protocol right and managing the complications. Well, at this point, we haven't even touched on the complications. So we can just do an entire new Just Ask on that one. I would love to do that.
We haven't even touched on, for example, showing the posterior mandible or the...
There we go.
Or there's a beautiful case of the anterior mandible, which is extremely difficult to treat. So I agree with you. Yeah. We should come back and do something.
Well, I hope our audience allows us to do that. I hope all our viewers from all the way from in Asia, Thailand, we've seen, to all the way to South America and anything in between will join us next time again. Now, Isabella, if you had to sum up the key message that people should take away from tonight, there's something to do with a learning curve, right?
Certainly. So the key message for sure is that this is very operator dependent, meaning that we really need to be careful in what we do. We need to make sure the protocol is followed to the letter.
like really precisely, no shortcuts, and no lousy surgery, if I may say. So a lot of training and a lot of ethical morality when we treat our patients. And also one other thing that I would like to highlight is trying to find alternative options, for example, conventional procedures, or using short implants, for example, in the non-aesthetic cases where it is appropriate. Everything has a specific indication. So I'm not saying one versus the other, but I'm just saying the diagnostic phase is crucially important, but this is for everything we do. So
exactly. Well, great final takeaways. If you're still watching and you're curious to know when the next EAO Just Ask is live, make sure you go onto YouTube and hit the subscribe button right now, because then you're the first to know when a first live video will appear. If you cannot get enough of these interactive chats about all the topics in implant dentistry, check out the earlier Just Ask which are available as recording. We talked with Alberto Salgado about the sinus lift. We talked with Michael Payet about ceramic implants. We talked about David Nissan about soft tissue management, and we'll talk about a lot more topics in the future. And one of the opportunities you have is that you can submit your own cases to our expert. If you want to do so, check out on our website, www.eao.org/justaskcasesubmission. And if you weren't able to write that down, it's in the description below the video. And submit as much information as you can, submit a clear question. But before you do so, make sure you have your patient's consent, because obviously that will be anonymously, but still be broadcasted on YouTube as well. And with that, Isabella, I'd like to give you a big, big thank you. Please go back into the comments after this live chat, because a lot of our viewers are thanking you and complimenting you and giving you great congrats for this great presentation. It was an honor and pleasure to talk about guided bone regeneration with you tonight. And I hope to see you all back in the next one.
Sure. Thank you very much. And thank you for all the people who connected and sent us a question. And Gerrit, it's always a pleasure to work with you.
See you next month.
Take care. See you next month.